So let's start, and we'll just talk a little bit about some of our objectives today. I want you to understand some of the basics of the histology of gastric carcinomas, and then we'll touch a little bit on some of the clinical presentations, and prognosis and risk will enter into that as well. This is pertinent because the WHO updated the classification scheme for gastric malignancies just last year, and so in many ways it's a step forward. It sort of simplifies a number of things that have been confusing in the past between the Lauren classification and other classifications, the main classification that were out there. And I'll sort of touch on what those differences were. But I think most of us are comfortable now using the WHO 2019 classification. I will say, however, that the CAP checklist still does have some of the Lauren classification entities there, in the sense that you can still check intestinal type or signet ring cell type and so forth in some respects. And I don't think those terms are going to go away, but they fit under the WHO categories in different sequences. So the bulk of tumors will fall into this first category of adenocarcinoma of the various types here that we see: the papillary, tubular, mucinous carcinomas, and then the poorly cohesive carcinomas that include signet ring cell populations, or the diffuse type, Linitis plastica type of carcinomas that are such bad actors. In addition, there are a number of other types that have less frequent appearance: hepatoid, lymphoid stroma, sort of a lymphoepithelial type carcinoma, micropapillary, somewhat resembling luminal B type breast tumors and so forth. Funded gland type, I'm not sure I've ever seen one of those. So they must be uncommon, or I must be slow to recognize. And then the rest of this list here is less frequently encountered. Certainly squamous cancer is very unusual in the stomach. Undifferentiated carcinoma, we occasionally run into that as we're struggling to figure out if it's a neuroendocrine tumor or not, and so forth. Gastroblastoma, I don't have any examples of that. That's a fairly new term for me, but it's a described entity, but quite rare. I think there are maybe 50 cases or something like that reported in the literature. And then the mixed carcinomas with neuroendocrine tumors there. This term has been around for a while. Previously was called mixed adeno-neuroendocrine carcinoma and so forth, but now it's MINEN, I guess, is mixed neuroendocrine, non-neuroendocrine tumors. And that can be of any of several different varieties that we'll touch on a little bit heading into that. So, I know classification schemes are kind of like the least interesting thing of a new resident's life and becoming acquainted with it, but it does give you a framework and a roadmap on which to begin building. Understanding that there are parts of this building that you may never get completed in your mind or your experience, but certainly the living room, the kitchen, and maybe a bedroom or two or something, those are going to get done because you're going to use those fairly frequently. So just to illustrate some of these things, this is a nice example of a tubular type. You see we have nice long elongated tubules. You may even have some sort of almost intestinal type differentiation in this tumor. But there can be some more diffuse type areas that you see here. And these are tumors that not infrequently arise in the setting where there's been intestinal metaplasia. So atrophic gastritis is a precursor for this type of carcinoma. When we think about poorly cohesive types, we think first of the signet ring cell carcinomas that you see here on high magnification. And not very many of you wear signet rings anymore, but they used to be quite common in terms of, class rings and things like that. So people use this to remind them of that characteristic based on, prior social norms and so forth, but we can still learn from that, just like we still use terms like hobnails, even though none of us has ever handled or hammered a hobnail. An interesting concept is whether or not there's such a thing as in situ poorly cohesive or signet ring cell carcinoma. Certainly when we see it invading, and it can be quite subtle, it does have some distortion of the architecture, but an in situ lesion has been posited and may be related to a CDH1 mutation, which is a heritable gastric cancer gene that's fairly specific for the diffuse types of neoplasia. And these patients will tend to have multiple diffuse cancers. Interestingly, this is also a lesion or a mutation that's associated with lobular breast cancer. And when we think about lobular breast cancer, of course, we realize that it also can have a signet ring type of morphology. It's very discohesive, infiltrative in sort of an occult, non-sclerosing pattern, and it has an E-cadherin defect. So there's certainly some understanding of the biology and what may be going on with this mutation, what may be malfunctioning as it affects carcinogenesis. Here's another examples of poorly cohesive cancers. Here's sort of a plasmacytic version. And I know you're looking at this photo and you're going, that just looks like chronic gastritis, you know? And that's the point I hope that you take away from this, is that diffuse carcinomas can be extremely subtle. And so in a gastric biopsy, patients with dyspepsia or other lesions, you know, just looking and scanning at low power may set you up to miss this. And I think this is one of the reasons why in many practices, the QA function of second review for most gastric biopsies, or certainly for any gastric biopsy in a patient with a history of ulcer disease or anything like that, is highly fruitful. I think I recall one of the first instances of a retrospective review of another pathologist's case that I came across a mistake was just such a case. And if you don't think that's a sobering experience in your first 4 months in practice, well, I've got news for you. It was very sobering because the person who missed the diagnosis was a very astute pathologist, and so there's your warning and sobering lesson for today. Interestingly, these lesions can also mimic macrophages or muci-phages, and sometimes we see that sort of xanthelasma type appearance, and when you see that, you want to make sure that you're not dealing with a poorly cohesive carcinoma. Here's a further example of a poorly cohesive, more Leonidas plastica type of appearance. But here you can see how similar this is to the cords and strands of lobular breast cancer. This is actually metastatic breast cancer in the stomach masquerading as poorly cohesive carcinoma. So let's come back to the tubular type. It also has its subtleties. Particularly at the GE junction, it can be a very challenging diagnosis because sometimes these tubules sort of just drift off down into the deeper structures, and they don't look terribly anaplastic or malignant, and they may just have sort of a adenomatous type epithelium, a low-grade dysplasia even overlying them. So these again are another insidious component of gastric carcinoma's infiltrative pattern that can be easy to miss. Now, some tubular types will exhibit a desmoplastic response, and therefore it can be a little bit more easy to detect. This probably is related to the adenoma carcinoma sequence of mutations that we see in the lower GI tract as well. Here's a nice example of the papillary type adenocarcinoma. And you can see here the nice small micropapillae and branching papillary structures, even a little clear cell type of change here. You know, if this were in the ovary, you might think clear cell carcinoma or something like that. But then the challenge becomes, well, what do you do when you have, as you see here at lower power, you have a classic papillary architecture here, normal overlying mucosa up here, and yet we've got pools of mucin here containing tumor cells. Is this a mucinous carcinoma? Is this a papillary carcinoma? Or is it a mixed carcinoma with both features? Basically the rules there is that to call it a mucinous adenocarcinoma, you'd like to see at least 25%. If you have less than 25%, you could certainly call it a mixed type with areas of mucinous differentiation and so forth. Those are not magical numbers. So certainly reporting what you see and quantifying what you see may also be just as good a rule of thumb to follow in practice. There are other variants. Here's a nice example of the hepatoid variant that I mentioned. And here's a very anaplastic variant. This one here on the lower left was actually an HCG producing choriocarcinoma variant. So that was quite unusual picture. In terms of clinical features of gastric carcinoma, there oftentimes are no early symptoms. The stomach is a rather large dilated organ. It's not going to be obstructed early. It certainly may ulcerate and so forth, but sometimes that doesn't always produce symptoms. The cardia, gastroesophageal junction area, and the antrum are the most common sites. That's where the turnover is. That's also where we tend to have the most prevalence of infectious etiologies like H. pylori, or where we may get intestinal metaplasia that will be leading to the dysplastic changes that we see either in Barrett's or Barrett's-related things or related to atrophic chronic gastritis. Geography is important. Certainly this is much more common in Asian populations. But once you start getting weight loss, pain, nausea, vomiting, those are generally late symptoms. Intra-abdominal spread is not uncommon, particularly with the diffuse types, where you may get a Krukenberg type of tumor involving the ovaries, or with spread to other mesenteric or peritoneal sites. And sometimes that actually is the first indication because, as I said, it may not present with initial symptoms at the location. Sadly, we don't have really optimal immunohistochemical characterizations that allow us to say a tumor originates in the stomach when we find a metastatic lesion and don't know where it came from or started. So that's one of the weaknesses. We can often say sort of upper GI tract and so forth, but we can't always say this is a gastric cancer that's metastasized to the such and such. In terms of molecular biology in these tumors, here's your board questions. c-Met mutations can be seen in both the intestinal and the diffuse types. The APC gene is involved with a fair number of the intestinal types. That's why I mentioned the adenoma carcinoma sequence, much less frequently in the diffuse types. KRAS, also an important mediator in many of these tumors, and HER2, not very commonly in the diffuse type, but up to 15% of the other types. And of course, that's the reason why we routinely do HER2 testing on gastric carcinoma biopsies. P53 is also commonly mutated in these tubular intestinal types and less commonly in the diffuse type. And I've mentioned already CDH1 in our previous discussion. In terms of reporting these lesions, of course, the checklist will provide the guidance for you, but it's important to maybe refer to that checklist and some of the notes of that before you begin your grossing, because you're going to want to think about what kind of procedure is being done, specifying the site, make sure you've got good landmarks and orientation, measuring your tumor, And then, of course, the microscopic features of histologic type, grade, depth of invasion, lymphovascular space invasion, lymph node status, and so forth. Those are the things that come into the key prognostic indicators that need to be in every report. And in terms of measuring depth of invasion, the optimal sectioning is one that gives you a nice perpendicular section that's transmural and allows you to define the pertinent landmarks. So you don't want to take something that's just through tumor you'd like to get something that gives you some measure of the surrounding normal tissue so that you have some measure of architecture and normal architecture that you can gauge things on. Obviously, T1 confined to the mucosa. T1B is where it invades the submucosa. T2 is beginning into the muscle. T2B is nearly through the muscle, and so forth. So these are the things that you want to remember are your important landmarks for depth of invasion. T3, you're involving the serosa, and T4, you're involving any adjacent structures. So any questions about gastric carcinomas, adenocarcinomas, so forth? I can't see you raising your hands, but don't hesitate to speak up if you've got a question. Okay, so neuroendocrine tumors. As I say, things can get a little bit steeper. So this is, sometimes people feel like this is the easy part, but it's really a little bit more complicated than it looks on the surface. So first of all, there are several different types of neuroendocrine tumors, even though the morphology may be, and the immunohistochemistry may be identical. So in the stomach, we have enterochromaffin-like cells, the ECLs, which tend to be the origins for types 1, 2, and 4. And we'll cover these types in just a minute. These tend to occur in the body or fundus and generally have a good prognosis. The enterochromaffin cells, the ECC cells, are the origin for type 3, the more sporadic and more common tumors, which can occur just about anywhere and have quite a variable prognosis. Okay? So type 1. Type 1 is the type of tumor that you see with autoimmune atrophic gastritis, where you've got a very strong immune drive, and these lesions can be multifocal. In contrast with type 2 tumors, and these are quite rare, it's usually occurring in the setting of Zollinger-Ellison syndrome or multiple endocrine neoplasia. So you've got some sort of a gastrinoma type of drive that is driving these enterochromaffin-like cells to proliferate. And type 4 is due to hypergastrinemia that's not related to autoimmune gastritis or Zollinger-Ellison syndrome. So this is the more sporadic, if you will, hypergastrinemia that is driving that. So looking at these a little bit more graphically here, another way to think of these is that the type 1 lesions and so forth are fairly frequent, but they don't get biopsied all the time because they tend to be multifocal, they're indolent, they don't usually cause problems, and so if they do resect them, they'll just snip them out. They don't result in gastrectomy type specimens. Female predominance because of course, the association with atrophic gastritis. Type 2, multiple endocrine neoplasia, Zollinger-Ellison syndrome. These have a reasonable rate of metastasis, and so these will be excised, but they're fairly uncommon, usually less than 1 or 2 centimeters. Type 3, I think these are the ones that I encounter more frequently, but these tend to be solitary, single lesions, and oftentimes a little bit larger, a little bit more likely to be invasive, and a little bit more frequent in males. So an important thing to recognize that if you see a male tumor, it's more likely to be type 3 than anything else. Type 4 lesions are quite rare, extraordinarily rare. They're sporadic, and they're also can be more frequently seen with the high-grade carcinomas, or they actually are the high-grade small cell carcinomas with a poor prognosis. Okay, so histologically, not a complex problem. They're much like neuroendocrine tumors that we see elsewhere in the GI tract. Nests of tumor cells, occasionally small lumina, maybe an insular pattern, maybe cord-like pattern, nuclei with salt and pepper type chromatin, maybe a few chromocenters mimicking small nucleoli, and slightly granular pink to amphiphilic cytoplasm. A little higher magnification just to illustrate this a little bit more. Here you can see the nice granular cytoplasm, the islet type growth or insular type of growth pattern, and the nice salt and pepper chromatin. Here, a slightly more ill-defined infiltrative tumor with more of a cord-like or insular pattern. But again, you see the nuclei are quite round. Occasionally, you get sort of this plasmacytoid appearance that you can see in some of these cells where the nucleus is pushed off to the side, and they resemble plasma cells, particularly because they have that eccentric nucleus and a fairly uniform chromatin. What you will not see, however, usually is a perinuclear HOF as you do in plasma cells. So here's an example from autoimmune gastritis where in addition to finding occasional tumors like this one here, or maybe a little bit one over here, what you may more preferentially see is just areas of enterochromaffin-like cells that are sort of streaming or continuous and hyperplastic in association with residual gastric epithelium. And here down here you see the intestinal metaplastic feature of this disorder. So in terms of grading, this is recently updated again with the WHO 2019. Grade 1 tumors, actually, I think there's one error here. I didn't update my presentation here. Previously, we were going on 2 mitotic figures per 10 high power fields, but in reality, that's 2 mitotic figures per 2 millimeters squared of area, and a Ki-67 index less than 3%. So I apologize for the error here in my slide. And grade 2 tumors have a mitotic rate between 2 and 20 per 2 millimeters squared, or a mitotic index of greater than 3 and up to 20%. Grade 3 tumors, of course, have more than 20, usually more than 20 almost per high power field, and a Ki-67 index of greater than 20%. Now, we'll talk a little bit about how we do the Ki-67 scoring in just a second. It's important to mention, however, that this grading system is really directed in the stomach only to the sporadic or type 3 tumors. So you wouldn't use this for the neuroendocrine tumors. At least you wouldn't use it formally. It's not validated for the tumors that are related to atrophic chronic gastritis. Okay, so Ki-67 scoring. So you count the number of Ki-67 positive cells and divide by the number of cells that you've counted. As Beth and Michael know, we have validated or demonstrated that eyeballing your Ki-67 scoring is not as reliable and as reproducible as the manual counting, or preferably the automated counts using one of our automated slide scanners or a quantitative algorithm. The question then comes up, what do we do if your grade by Ki-67 index is higher than, or the mitotic count is higher than the Ki-67? What if there's a discrepancy? And the answer is really that you go with the higher grade. By either method is preferred. So if you've counted and you have 10 mitoses per 2 millimeters squared, but you're only getting a Ki67 index of 2.9%, then you're going to go with that higher grade and call it a grade 2. So that's just some sort of takeaway points with regard to Ki67 scoring and counting. The other option, of course, is a manual count using a printed photograph or something of that sort, and that's very tedious. Nobody likes to do that, so whenever possible, I think the automated method is preferable in terms of the use of your time, and probably also reliability and the ability to count 2,000 cells. Because if you're going to count manually from a printed photograph, you'll probably get 500 cells in a print of a 40x field, but you may not, so you may have to count multiple images. All right, so when you have a tumor that's definitely malignant and it has neuroendocrine features, that falls into the category of neuroendocrine carcinoma, and you report and stage that just as you would other gastric carcinomas. And this, of course, comes in both large cell and small cell variants. And these neuroendocrine features are primarily the nuclear features that we're concerned about here. It doesn't necessarily always require immunohistochemical demonstration, although I think most people would like that to be concordant. In terms of reporting for neuroendocrine tumors, pretty similar. Specimen type, tumor site, size, multi or unifocal is important. So sampling areas that may look potentially involved is important. Histologic type, margin status, and of course using the T&M staging system. And if it's associated with one of these syndromes, you'll want to include that. Okay, so was that too steep a run? Maybe it's downhill from here. So I'm sure we'd all rather be in the mountains of Colorado than here in the heat of Oklahoma, but we've still got a ways to go before we can do that. So the mesenchymal tumors of the stomach are uncommon and less common. The most frequent one, of course, is the GI stromal tumor, and then Schwannomas, Glomus tumors are next in frequency. And then there's all the rest. So let's start with GI stromal tumor. And one of the key things to emphasize here is that this is an intramural or originating lesion. If the lesion is centered in the submucosa, you better think twice before you call it a GIST. If the lesion is centered on the adventitia, same thing. But if it seems to be centered within the muscularis propria, odds are it's a GI stromal tumor. As you know, these tumors can have a spindle-shaped configuration or an epithelioid configuration. They can occasionally have sort of signet ring type appearance, as you see here, mimicking other tumors more interesting. They can also have areas of necrosis. The mutation most commonly associated with this, and from which we have seen such dramatic response, is the c-KIT mutation. But you can also have other mutations, notably with platelet-derived growth factor alpha or with succinate dehydrogenase. And since these may or may not have specific targetable drugs pertinent to them, sometimes mutation testing comes into play, and we'll cover those circumstances. This is usually a tumor of adults, usually middle age. And there's some association with neurofibromatosis type 1, more particularly when these lesions are found in the small bowel, not so much in the stomach. So when do we do mutation testing? Well, if you've got typical morphology and it's CD117 negative, then that may be an indication to verify that you've got a variant mutation or something else going on. If you have the epithelioid type morphology, that oftentimes warrants mutation testing. And of course, if your frontline, first-line treatment has failed, they progressed on that, then the clinicians will be clamoring on you to do mutation testing to see if they have a PDGFA alpha type mutation. In terms of prognosis and reporting and so forth, obviously the type of specimen, size, and site of the tumor. These are critical. So good measurements, good evaluation of where it's coming from. The histologic type in terms of spindle morphology or epithelioid morphology, mitotic rate. So here's one with 3 per 1 high power image. Presence or absence of necrosis, and then the risk grouping. And this is based on follow-up studies, and the chart is available within the notes section of the CAP checklist. Very, very convenient. Another reason to refer to those notes regularly when you're working on a case, and not to just take the printed template, which does not have all the notes. Obviously, margins, biomarker status in terms of immunohistochemistry. So here's the table from the CAP cancer protocol. This is obviously broken down according to size, mitotic rate, and location. A couple of things to note here that even in large tumors, you can have a fairly good prognosis, less, 10% or so risk of progressive disease in the stomach. Once mitoses start getting high, however, and your mitotic rate is high, then you switch that. Of note is that there are certain categories where we just don't have enough data. For example, duodenal lesions of intermediate size. We don't have a lot of data there. Same thing for rectal lesions and so forth. Some of these intermediate sized lesions and so forth. But the other thing to note here is that, as you can see, just say a 10 centimeter lesion, low mitotic rate, it still has a very high rate of progression if it's occurring in the jejunum or the rectum versus the stomach. And so accurately and precisely defining your location is really critical to specifying outcomes. Just a quick word about staining. You can see a variety of patterns. You can see a nice diffuse, this is CD117 staining. You can see nice diffuse cytoplasmic staining. You can see positive dot-like staining. This is also classified as positive staining. Then you can see a membranous pattern of stain as well. These are all consonant with positive stains. What you see here, though, in this more anaplastic variant with just a few positive cells, this should be probably called negative because you're probably either seeing here just sporadic peroxidase activity or some other activity. And so this is the lesion where negative staining might lead to testing for which specific mutation was involved. These lesions can also have lymphovascular space invasion, so it is important to be aware of that and to evaluate, particularly in the more epithelioid lesions, they can have that appearance. Okay, so let's touch on schwannoma. So again, here we see grossly. You should be able to look at this grossly and evaluate where is this lesion occurring. Is this in the adventitia or is it in the muscularis propria? Is it in the submucosa? Well, it's not. Here's our mucosal surface. Here's the submucosa. So this is either adventitial or outer portion of the wall, because this is not sort of barbelling up into the mucosa. This is sort of exophytic onto the serosal side of things. But that said, these can be present in a mucosal lesion. And this is one of the pitfalls to be aware of. So here's gastric mucosa. They give you a history of a gastric mass. They biopsy the lesion, and you get down here to the submucosa, and you see this lymphoid cuff. Very frequent finding in schwannoma is to have a lymphoid cuff. So just be sure you don't fall into the, oh, this must be lymphoma category versus, oh, maybe we didn't get the real lesion. So recognizing and remembering that this lymphoid cuff can be present is a nice caveat to be aware of. Morphologically, schwannomas have a nice characteristic morphology, spindle-shaped cells, variable cellularity, and you can see here kind of pointy end nuclei. You can see these are not cigar-shaped; these are spear-shaped nuclei. We got, let's see, I think I have one more high power here. You can also see sort of a myxoid change in these lesions as well, which is nicely demonstrated here. Okay, glomus tumor. I didn't think I would ever see one of these. These are not terribly common, but we've actually come across several. Dr. Gillies had a very nice case a few years back that we presented in a meeting. So this is a tumor that can occur in the gastric wall. It's not just a distal digit type of tumor, but has in the stomach has a fairly interesting morphology. So it tends to be spindle shaped, but can have sort of a almost a neuroendocrine appearance in some respects, especially if you're just looking at a small biopsy. So it has round nuclei, fairly bland chromatin. It doesn't look particularly exciting. But it also will have a tendency towards forming slit-like spaces. These are hard to appreciate in a small biopsy, but if you have a resection specimen, they'll jump right out at you. These long slit-like spaces that don't seem to be vessels. Here you see them, you know, just all through here. And so if you see anything that resembles that, don't be afraid to think about glomus tumor. Now, of interest is the fact that although these tumors tend to have vascular invasion, they tend to have a very indolent behavior. So do your calponin, actin stains, and so forth, and make sure you rule that out in something that doesn't have a typical GI stromal tumor appearance and maybe has these slit-like spaces. Hematolymphoid neoplasms. So of course, we do see these in surgical pathology, and our colleagues in Hempath like us to share them with them, of course. There principally are two main versions that you're dealing with. There are those that are H. pylori associated, and those fall into the two categories of MALToma, low-grade lesion, and diffuse large B-cell lymphoma. This is most likely due to the fact that you have lots of antigenic stimulation going on with H. pylori, and that produces inflammation and oxidative stress, which can then lead to the development of a clonal response in the lymphocytes. There are some perplexing questions, and that is kind of where do we draw the line for lymphoid hyperplasia? Where does it become lymphoma? And why and which of these lesions will respond to anti-helicobacter therapy and which will not? I think these questions are interesting questions about the very nature of neoplasia themselves, but certainly have to do with our diagnostic acumen. So MALToma is a marginal zone B-cell lymphoma that has very characteristic lymphoepithelial lesions and will show other signs of tissue destruction. These are, again, usually CD20 positive cells, and that's typically what I've used to differentiate them, is when you see a predominance of CD20 relative to CD3, which would be the normal component of the lamina propria, then you start thinking about lymphoma. These cells tend to have, sort of cleared out cytoplasm, and you can, if you want to demonstrate the lymphoepithelial lesions, you can do that either with a negative stain, as here the keratin stain showing you the lymphoepithelial lesions invading or involving these otherwise typical epithelial spaces and giving you this sort of moth-eaten, ratty appearance. Or you can do it with the CD3 stain or some sort of a cocktail, of course. So here's an example of the CD3-CD20 mismatch. Here's the CD20 stain here on the left, a CD3 stain here showing a fair number of cells, but not the predominant population. So I think that has moved beyond being just a reactive inflammatory gastropathy and has become a clonal neoplasm. Now, some of these can have plasmacytic features. You may even have little Russell bodies and so forth. I had a case the other day of Russell body gastritis with lots of these in it that was not clonal, and it was predominantly plasma cells that did not have the MALToma features. But if you have the plasmacytic feature, then sometimes kappa lambda can help you define clonality if you want to go that direction. Now, the diffuse large B-cell lymphomas in the stomach more frequently would be confused with diffuse type of carcinomas, the poorly cohesive carcinomas. These will tend to be older patients, have ulcerations, even though they may have a precursor such as follicular lymphoma or a MALToma as a response. But you can see here at this high magnification how you could consider things like anaplastic carcinoma or undifferentiated carcinoma, poorly cohesive carcinomas, and so forth. And so including diffuse large B-cell in your differential is worth bearing in mind. There are other lymphomas like the double hit lymphomas that may have these other features, combination of diffuse large B and Burkitt's or B-cell lymphoma unclassified. These, of course, in our subdivided pathology department, most likely will go to the heme path people to sort out and to meet all of the needs of the hematologists who are going to treat them. But these generally have very high Ki67 and will have other B-cell markers like CD10 and so forth. And of course, the mutation evidence will be there as well to support that. Mantle cell lymphoma, another low-grade B-cell lymphoma, can also occur in the stomach and may be more commonly seen in the setting of sort of this polypoid appearance. So if you're seeing lots of lymphoid aggregates in the stomach, that may actually be a manifestation of mantle cell lymphoma. These tend to be slightly more aggressive certainly than the MALTomas, and would of course be positive for CD5 and cyclin D1 as characteristic markers for that neoplasm. Myeloid leukemia shouldn't be excluded. Granulocytic sarcoma can occasionally occur here. And if you remember to think about it, then you'll probably remember to do the stain. So you're thinking of your myeloperoxidase, CD34, CD117 should be useful markers to help delineate that entity. These usually do not have characteristic lymphoepithelial lesions. As you can see here, the glands tend to be preserved and the infiltrate is between the glands. Metastatic disease also can occur in the stomach. So as you think about metastatic carcinomas or tumors that may come to the stomach, it's important to think of that. But probably the most important things are to remember the ones that can mimic primary gastric neoplasms. And those fall into these two entities. You probably surmised that we would talk about lobular carcinoma, but melanoma actually is another one that should be considered as well. Things that melanoma can masquerade as. Here's a nice example of what looks like diffuse gastric carcinoma. You see the infiltrate here in between the cells. It's sort of Linitis plastica-like. The cell size is fairly small. And you see, some normal, maybe even some abnormal parietal type glands here. But this, in fact, turned out to be malignant melanoma. Here's another example where melanoma is mimicking a diffuse pattern lymphoma. And it could be considered a diffuse large B or something like that in your differential. So you can see the sheets of small blue cells. And of course, higher magnification, you might find pigment, you might find cherry red nucleoli, and so forth. But if you're thinking things in that category, you need to remember that melanoma is the master mimic when it comes to its metastatic sites. Melanoma can also mimic epithelioid gist or Schwannoma. Here's sort of an epithelioid appearance. You can see the numerous mitotic figures. And here we've got the cherry red nucleoli that should tip us off to thinking more towards melanoma than towards a GI stromal tumor. And here we can actually see some sort of intraepithelial component to this maybe as well in these clear cells within the glands that could be distinctive. Of course, melanoma markers can even be confusing as well. So we've mentioned a few other things that can be S100 positive, Schwannoma. We've mentioned something else that could be positive with CD117 when you think about myeloid sarcoma. And of course, we know that picomas can also be HMB45 positive. So sometimes we may want to go to one of the more specific markers, the SOX10 or MITF, to be a little bit more specific. So here's the test case. Is this a primary lesion or a metastasis? Okay, show of hands. How many think it's a metastasis? Philip, you'll have to report.
Let's see.
Any hands up?
2 people think that it's
two people think it's a metastasis. Okay, well those 2 get red stars because this is metastatic lobular carcinoma. So we've mentioned that this subset of gastric carcinomas can be may express ER/PR like these the CDH1 mutated tumors and be negative for ecadherin, but this is a patient who did have lobular carcinoma and who did have metastatic disease that involved the GI tract, including the stomach. So I guess the thing to remember is that if that's in your differential, it could be a little bit challenging, and you may even want to look at the molecular germline mutation in those patients to see if they have a CDH1 mutation. Other tumors that we can see in the stomach as metastatic lesions can include renal cell carcinomas, lung, pancreatic carcinomas, and leiomyosarcoma, either as a primary, although that's very unusual, or a metastatic lesion. So that kind of wraps up the malignancies that I wanted to talk about today, or that I had ready to talk about today. And so let's just pause for a moment and see if anybody has any questions. So unmute and pop up with questions or comments that you'd like to add. Well, hearing none, I guess we can go ahead and close. Thanks very much for joining me, and I hope that this was useful to you. We will try to put out some unknown slides and post some additional case examples, either through video means or other means, in the coming days. So, thanks everybody.
Dr. Hassel.
All right.